Hey everybody, Brian Boyle here, and welcome to the Mesh Tongue. Today we're going to talk about the boy, it has been a long day, platelet-rich plasma, and I've got a special guest, Dr. Trevor Williams, also known as the Run Doctor. And as we go into this, what is platelet-rich plasma, and who is it good for, who is not appropriate candidate, and hopefully get some great information. So we'll be right back. All right, so we're back, episode 177 of the Mesh Tongue. My name is Brian Boyle, and like I said, I have a special guest with you, Dr. Trevor Williams. And Dr. Williams, thanks for having me today. Dr. Williams and I met on a Facebook group, oddly enough, just trying to help some other folks like yourself out. Dr. Williams has a big social following. You can find him, and I'll let him tell you where in a second here, but you can find him on social media, but you can also find him in his offices here in Utah. So the reason I wanted to bring him on today was to discuss PRP, or what's known as platelet-rich plasma, and why it may be a good solution for you as a runner, why it may not be. And Dr. Williams, could tell us a little bit about PRP and what it is.
PRP stands for platelet-rich plasma, and so if we take blood out of a patient, there are several components to that blood. Some of it is serum, or just kind of the water component to it. Others components are the cells, and then the fragments of cells. There are proteins, there are other chemicals that are inside that blood. But when we take blood and put it into a centrifuge, which just essentially spins it around really fast, it will separate out the components of the blood. Heavier components sink to the bottom, lighter components to the top. So if you centrifuge it, you're going to get essentially three layers. The top layer being the serum or the fluid part, a middle layer called the buffy coat, which has platelets, and it has other semi-cellular components to it, and then the bottom layer are the red blood cells. And when we separate out that buffy coat, there are platelet components in there, and so platelet-rich plasma is essentially a process where we withdraw blood, spin it down, and then that platelet layer is kind of sucked out or just aspirated, and then we separate the platelet-rich part of that. And then that can be used for a variety of purposes. It's been used for decades, but it can be used for wound healing. It can be used for, in the case of tendinopathy or fasciopathy, it's even injected into joints to try and encourage healing process. But that's in essence what we do to get it. And there are several components to platelet-rich plasma. Platelets themselves are just a small little part of the blood. And if you think about them as kind of a broken down cell, but there are little proteins and growth factors inside of those, so when they interact with damaged tissue, they release these growth factors that can stimulate wound healing. They can stimulate growth of blood vessels and skin and a whole variety of things. So there's a long list of growth factors that are in there that can help to augment healing processes in the body.
So what kind of conditions are you typically using this for runners? What are there certain conditions that are better? If somebody comes in and says, "Hey, I've got a mild ankle sprain," versus somebody that's got a chronic ankle sprain, or somebody that's got plantar fasciitis, is there something that's you're finding that it's working better for with runners?
It's a very good question for runners. Usually, what we're dealing with are chronic problems. They could be, for me, as a foot and ankle guy, we're dealing with tendons. Either the Achilles, the peroneals, the posterior tibial tendon, or the fascia is probably the most common thing. I think about 20% of what I see in my clinic here is plantar fascia. And the indication or use of platelet-rich plasma in an instance of a runner would generally be an injured piece of tissue we need to stimulate the healing process or the healing cascade in. The body has a natural process where by the tissue becomes inflamed to start with, and then it begins to heal itself, and the body requires the recruitment of certain cells to properly follow that healing cascade. In cases of chronic injury, the body's gotten out of sync, and it stays in this inflammatory state too long, and that begins to damage or break down the tissue. And so in those instances, for somebody with a chronic Achilles tendinopathy or chronic fasciitis, or even some of those with chronic ankle or joint pain, we can utilize platelet-rich plasma as an injection into that area to stimulate the healing process. So in essence, what you're thinking about is a damaged piece of tissue that's not healing on the proper timeline.
Okay.
And we want to initiate or help the body get back on track. So we need it to heal when it's not. We inject the platelets in there to do that.
So when we're talking chronic, what are we thinking? Runners want to be healed 30 seconds ago, right?
Yes.
So is chronic like 7 days? Is it 3 months? So give us a time frame on chronic. I think that's where a lot of people are like, I just want this to be better, and I want to be running again. What?
Yeah, it's all. Most of our runners can tell you that an injury is. It can be just everything from nagging to devastating because it'll stop you from training. And for us to stop running, it really can impair things. So the question about chronicity, or when does something go from an acute to a chronic state, usually the acute stage is anywhere from about 1 to 4 weeks. And so there's an acute inflammatory phase that lasts anywhere from 3 to 5 days, maybe up to a week. That's where we expect there to be inflammation. In fact, there's certainly a lot of logic. We don't want to suppress the inflammation in that phase. And that if we do, we might decrease the healing capacity of the body. Inflammation is normal. It's necessary.
Right.
But if it sticks around, like I had said, too long, it becomes an impairment. We call anything in that first probably week to 4 weeks as an acute injury. Anything from that 1 month to 3 month we call subacute, and then anything longer than 3 months we would consider an acute injury. So to answer your question, PRP is not the best therapy or treatment in the first probably 3 months. If something has become chronic, in other words, it's out of that normal healing cascade, then after 3 months we might consider it as an adjunct to other treatments to try and help it out. So long answer to your short question, which was longer than 3 months.
Okay, right. So I was gonna say, because I know a lot of you out there, it's like, oh man, I miss a day, and it's like it's an eternity, right? And it's like to stop for a week or 2 weeks is complete devastation at that point. So if you're thinking about this as the first line of defense, PRP is not the first line of defense, and I'm sure you get that. Some of the questions people are doing their internet search on Dr. Google, and it comes in and it's like, oh hey, I've got this, and this, and I've got this laundry list, and I've heard PRP is going to be great because I saw so and so had it done, and I'm sure you get these in the clinic where somebody comes in and they're very well educated and they want PRP, and you're like, well. Are there times when you've had to talk people out of PRP that it just wasn't right for them, or they weren't chronic enough, that sort of thing?
There are, like with any therapy, whether you're dealing with PRP or cortisone injections or physical therapy or surgery, you have to decide if that therapy is going to really address the underlying problem. And so there are instances where people will ask for PRP. And it's clear that it's not chronic enough to really benefit from that. Or there are cases where the tissue damage is such that the PRP is not going to be sufficient to initiate a healing cascade. So there are instances where you're kind of on either end of the spectrum, and you have to tell patients it's really not the best treatment for them. There's not really a downside to doing PRP, so you could do it in many instances. It's just you have to be aware of where you expect it to work and where it's not. If it's not really going to help, then it really doesn't justify the therapy from a medical standpoint. The other part is PRP is not covered by most insurance carriers, so it becomes an out-of-pocket. It's an out-of-pocket cost, and that can range depending on who obtains the cells for us and what we have to do to inject it. If we need ultrasound guidance, we're probably anywhere from $600 to $900 out of pocket. Now, for somebody who's facing the proposition of a surgery, that might be a nice alternative to saying, hey, rather than me undergoing surgery on my body, I could have a PRP injection and hope it helps. And in that instance, it's valuable. But for most people, the side effect isn't physiological; it's financial.
Right.
So So anyway, it's a good therapy, but you've got to use it in the right instance.
Okay. Yeah, so I think that's the key with everything, right? I mean, it's obviously having the right tool for the right condition, and my hope with this today was to basically give you an understanding of why PRP may or may not benefit you. I know there's a lot of people that ask a lot of questions and are always looking for the next thing. So PRP is relatively, if we think about PRP in the scope of medical tools that we have. How long has PRP been around, and is there more and more research being done on it daily, or is this something that's kind of like it's underground still, and because I know there's a lot of people this may be the first time even hearing about PRP.
Yeah. It's not underground, really. It's pretty well known for those of us in the medical field. For the average consumer, it might not be something they understand. PRP's been around for, if I can think back to some of the data, goes back, not platelet-rich plasma so much, but autologous blood. So another version of this is to just take the blood out and then inject that. The data with that's not quite as strong, but that data goes back about 100 years. But platelet-rich plasma has probably been in the last 10 or 15 years gaining traction. There's good data in certain parts of the body with it. For example, oral maxillofacial surgery. So when oral surgeons are reconstructing a jaw, there's pretty good data. There's some data with the spine. But general orthopedic and podiatric literature is relatively lacking. Or if it's there, the study quality is okay. And that's really where, if you look at the recommendations of most professional organizations, they'll say that it's not, the data's not strong enough to recommend that everybody get this, right. But it's certainly an adjunct or an option for people who are faced with other surgical or options, or they just have to live with the pain. So it's been around for a long time, yes, but the data's mixed. There's not enough to really recommend it in every instance. So we have to measure who's it appropriate for. Right. And is it going to fix the problem that they're dealing with? So
the not so exact science of medicine that as we've kind of come to see. So Dr. Williams, how would somebody get a hold of you, and what makes a good referral? Who makes a good patient for you? If somebody's watching this and they say, that Dr. Williams was great, I'd love to go see him and support this.
The best way to get a hold of me, we've got the practice website. It's www.healthierfeet.com. That's my practice website. But the running side, which I deal with a lot, that's just kind of been my niche since I've been in practice for almost 15 years, has been the biomechanical side. So the running, and myself as a runner, it kind of meshes well. But that one's therundoctor.com. We have a website there that has videos. Has injury information, and you can get a hold of us there. We're on social media, on Facebook. I believe we've got an Instagram. I've got a girl that manages more of that for us. And then we've got a YouTube channel that we're working with to put exercise videos on that's kind of in that initial infancy.
Right. So I think the YouTube is the Run Doctor. The Run Doctor. I think so, I was looking at your Instagram is Utah Run Doctor, and then definitely check them out on Facebook. So Dr. Williams, I appreciate your time today. Thank you very much for being with us, folks. If you find some value in this, please share this with your friends, your family, your training partners, whoever that may be. Reach out to Dr. Williams if you've got questions. He's in Utah. He's got a couple different practice locations that you can find him online, like you said, at the website. I'll put that on the show notes here. Also, please don't go hurting yourself to come back, but we'll see you again next time. This was a wrap for the Mesh Tongue, episode 177. We'll see you again later. Take care.